Reminder calls to all the faculty is also given, sir. We'll start the event 5:30 sharp.
Yeah, sure. Okay.
Uh,
Good evening. Am I audible? I'm Dr. Nitya.
yes, ma'am.
Yeah. Okay.
Nitin sir, could we start with the session?
Yeah, sure. So, yeah.
Okay, sir. I'll start with the opening.
Good evening, everybody. Welcome. Oh, okay, you start.
Yes, sir. Yes, sir. Just give me a moment. So, very good evening, everyone. A warm welcome to all our distinguished faculty members and participants joining us for today's IIO Expert session on breast cancer. I'm Joshi Roshni, your host for this evening. This virtual academic meet is being organized by International Association for Integrated Oncology, IAIO. Today's session will focus on HER2 low and ultra low breast cancer, a rapidly evolving area that's reshaping diagnosis and treatment strategies. To set the context for today's proceeding, now I would like to invite our program director, Dr. Nitin Raj Daniel, medical oncologist at Baby Memorial Hospital, to deliver the opening remarks. Over to you, sir.
Good evening, everybody. So it has been a flurry of many meetings and everything, and I think the most intriguing and the most important is how to tackle triple negative breast cancer, or how to tackle HER2 low metastatic breast cancer as a whole. So HER2 low metastatic breast cancer as such is approximately found in around 50 to 60% of the breast cancer cases. And traditionally, we had this just HER2 positive breast CAs and HER2 negative breast cancers. So now we have got this HER2 low category where the IHC 1 plus or IHC 2 plus without HER2 gene amplification has been studied very much. And there is HER2 ultra low category, which increasingly is used to describe HER2 IHC 0, but with faint or minimal membrane staining. So this HER2 low subtypes as such has been associated with very poor prognosis compared to the other types of breast cancers. So in the wake of the recent ASCO and ESMO guidelines, many breast 06, the Ascent 03, to target HER2 low tumors, and how to sequence of this, I would like to start off the proceedings. So yeah, over to you.
Thank you, sir. Thank you so much for those wonderful opening remarks and setting the tone for today's discussion. We now begin with our first scientific session titled HER2 low and ultra low targeting in advanced breast cancers. It's my pleasure to invite Dr. Nithya S., Associate Director and Senior Consultant, Medical Oncology, VS Hospital, Chennai, to share her insights on this important topic and evolving treatment domain. Ma'am, over to you, please.
Thank you for the introduction. I think we had a pathologist to talk before me, and it would have been very apt if the pathologist had actually given us insights on how the standard HER2 3 plus is different from the ultra low and low. But nevertheless, I will just start and appraise of the recent advances in management, and we can look at the pathology part a little later. So as Dr. Nitin has just mentioned, that ultra low and low HER2 are seen as very important developments in the management of breast cancer, especially in advanced metastatic breast cancer. So 10 years earlier, we used to ask why there is HER2 2 plus and what is the significance. And today we have an answer, which is targeting low HER2 and ultra low HER2 with the help of the antibody drug conjugates. So we will look at how these kind of therapies developed and a few guidelines from ESMO Living Guidelines. So on the next slide. So this is the basic question. Do HER2 antibodies work if HER2 is negative? So this was from the previous trials, the NSABP, B31, all those initial trials where they found there was no benefit of adding adjuvant trastuzumab in non-amplified, non-overexpressed tumors. So that is IHC 1 plus, which is non-expressed, and IHC 2 plus, which is non-amplified. So, and that led to the guideline of not adding any HER2 targeting agent when there is a HER2 1 plus or a 2 plus FISH negative. But now we know that the situation is different. The next slide. So targeting low and ultra low. So this, I think we will be dealing in detail with the next speaker. I will let them do the honors because it's quite a complex scenario where you have a percentage of expression, the completeness of expression. There are many factors to consider when you actually label them as IHC 1 plus, 2 plus, 3 plus, or IHC 0. So this is what we know, that IHC 2 plus and FISH negative and IHC 1 plus is HER2 low. IHC 0 and faint there is faint incomplete membrane staining in less than 10% of tumor cells is HER2 ultra low. So this is what we are going to look today. And these were basically developed in various kinds of trials, especially from the Destiny Breast 04 and 06, which use trastuzumab deruxtecan in these category of patients. So next slide. So how to define HER2 low breast cancer? So there is a static definition from the pathologist where there is a circumferential membrane staining that is complete, intense, and in more than 10% of tumor cells, which is defined as IHC3+, and that is technically HER2 positive. So we don't need to do any further testing after that. So once there is weak to moderate complete membrane staining in more than 10%, it is labeled as 2+. So it is a very relative thing here. So we need a very good pathology backup for defining whether it is HER2 3+ or 2+. And when the HER2 is 2+, IHC is 2+, we do a reflexive-ish testing. And if it's positive, we call it as HER2 positive disease and the patient is eligible for HER2 targeted agents. If it is negative, then we label them as HER2 low. In today's era, earlier it was negative. So most of these categories go under the triple negative if the ER is also negative. So when there is incomplete membrane staining that is faintly or barely perceptible in more than 10% of tumor cells. So that is IHC 1+, and that is also labeled as HER2 low. We do not technically do an ISH testing in such patients. If there is no staining observed, it is called HER2 null. And if there is membrane staining that is incomplete and is faintly or barely perceptible and in less than 10% of tumor cells, we call them HER2 negative. So overall, when we look at HER2 positive breast cancer, it is around 15%. HER2 negative breast cancer is around 30 to 40%. And HER2 low breast cancers is around 45 to 50%. So what was defined initially on the basis of hormone receptor status now is based on the HER2 status. So earlier we used to say it was either ER positive or negative. And amongst those, we have HER2 positive and negative. And that gave us 4 categories where the patient would either be labeled as hormone receptor positive, HER2 rich, triple positive or triple negative. Now, most of the, in days to come with the number of antibody drug conjugates, I think the entire classification, the matrix itself will be based only on HER2, whether it's HER2 positive, HER2 negative or HER2 low. And it is very important to understand that it is the pathologist who tells us whether it is low or ultra low or a HER2 positive disease based on the membrane staining. But in dynamic definition, HER2 low status changes over time. So at which point do you define a tumor as HER2 low? So whether it is the primary tumor being 1+, rebiopsy after endocrine therapy, the HER2 becomes 0. Most recent therapy, HER2 is 0. So there are so many dynamic definitions where the HER2 initially is 3+, and after giving the conventional HER2 targeting agents, it becomes 1+. So how do we label these patients? Whether it is really HER2 positive, whether they're going to benefit from HER2 targeted therapy, whether we label them as a triple negative, forgetting about the hormonal receptor status at this moment. So it's a very dynamic definition. We don't have a conventional definition because in advanced breast cancer, most of these patients would have already experienced some kind of therapy previously. Next slide. So it is essential to report the HER2 IHC reports. So I would advise all the postgraduates here who are listening to me. It is important that you document the IHC report in the diagnosis. So many of us in the earlier phases, we never gave importance to the 1+ and 2+. We used to say HER2 positive if the patient had a 3+, and just HER2 negative, it was any other category. So I would advise you all to write, even if it is 1+, even if it is 1+, right? HER2 is negative, and in brackets, please put 1+. This kind of data might be really useful in later times when you're looking for treatment failures, especially in patients who are on endocrine therapy and they fail on endocrine therapy very early, like primary or secondary endocrine failures. The HER2 receptor status, the positivity on IHC could be a reason for the endocrine failure. So please document the HER2 IHC results wherever you're writing a diagnosis. So who are the patients that are eligible for HER2, the trastuzumab deruxtecan, which is the targeted therapy available now for HER2 low disease. So when there is HER2 null, IHC 0, there is no need for any targeted therapy for that. When the HER2 is low or ultra low, as I just explained, they are eligible for HER2 directed therapy. And whenever there is an amplification on ISH or HER2 3+, the patient is eligible for HER2 targeted therapy. So we don't look at TDXD first, we look at HER2 targeted therapy initially, and then we switch over to TDXD whenever there is a primary failure. Next slide. So this is trastuzumab deruxtecan. I think all of you would have really spoken so much about this revolutionary drug, the first drug to really create a very big ocean of revolution in patients with HER2 positive breast cancer. It changed the way we looked at HER2 positive breast cancer actually. So it is a HER2 targeted ADC with 7 key attributes. So basically you have it's a conjugate. So antibody drug conjugate, which has an antibody and a payload, which is deruxtecan. That is the active moiety. And it is a topoisomerase 1 inhibitor payload. There is high potency of payload based on a cell-free assay, topoisomerase 1 mediated DNA relaxation assay. This is a payload with a short systemic half-life, also meaning that it would not create a prolonged side effect. Highly membrane permeable, which may enable a bystander effect. So it also affects the adjacent all adjacent cells which are expressing HER2. Stable in plasma, designed to be cleaved by lysosomal enzymes overexpressed in tumor cells. So this is really very important that it becomes active inside the body without any need for any kind of an activator. Next slide. So this is the very early study of a phase 1b TDXD in HER2 low breast cancer. Around 54 patients were there. So when you look at the immediate questions, so HER2 expression is agnostic. Is HER2 addiction needed for activity of this ADC? Or if HER2 addiction is not needed, then do measurements of low levels of expression matter, and how? So they found that the drug was very, very effective. And when you look at the top graphs, in all patients, they produced a very good response. And the response was very good in HER2 low and slightly lower in the HER2 ultra low, or the 1+, what you call as ultra low. So I think that was the benefit was there irrespective of the HER2 staining, which was more in the 2+ and rather than the 1+. Next slide. So this is the phase 2 trial of TDXD, regardless of HER2 status. So this was a DAISY trial when you have HER2 expressing, HER2 low, and HER2 non-expressing. When you look at the HER2 overexpressing cohort, there's a huge response, and the response starts reducing as the HER2 expression goes down. So are these tumors HER2 low, or are they simply HER2 normal? That is not HER2 positive. So HER2 addiction, meaning reliance on HER2 pathway for cancer cell survival, is strictly not needed. So irrespective of the HER2 status, the drug works. That means that it is not dependent on the addiction. Next slide. So Destiny Breast 01 was one of the earliest studies, very popular phase 2 study of trastuzumab deruxtecan in HER2 positive advanced breast cancer, previously treated with TDM1. So that was the standard of care at the time when TDXD was first tried. And many of us, I think, from our generation, we know that TDM1 was in clinical trial when we were students, and it received a very accelerated approval. And it also created a big revolution in patients with HER2 positive disease with relapse, especially those at risk of brain metastasis. So this study was in patients with HER2 positive unresectable or metastatic breast cancer who were previously treated with TDM1. Trastuzumab deruxtecan achieved very strong durable benefit. When you look at the graph that is there, the image that is there, you can see that Enhertu monotherapy delivered durability that resets expectations to patients who progressed on second-line anti-HER2 therapy. So most of these patients would have been exposed to trastuzumab initially. There was no pertuzumab at that time. So, and many of them have already received a large number of doses of trastuzumab, the emtansine as well, and now with trastuzumab deruxtecan. So that was a very significant study. Look at the median duration of response of 14.8 months and a median PFS of 16.4 months. This was the first time this kind of a result was achieved in a very aggressive disease. Next slide. So this was the Destiny Breast 02. So this was again TDM1 treated MBC, the archive sample which was HER2 positive. A central analysis was done. Primary endpoint of PFS. They were exposed to trastuzumab deruxtecan or investigator's choice of therapy. So that could be either trastuzumab plus capecitabine or lapatinib plus capecitabine. The median PFS for TDXD was 17.8 months compared to 6.9 months for the physician's choice of treatment, the hazard ratio being 0.36. This was a very, very significant study. Of course, this was against the physician's choice of therapy compared to the previous one, which was against the standard of care. So this again was a very positive trial, and this also led to one of the approvals for TDXD. Next slide. So Destiny Breast 03 was the first randomized phase 3 study of trastuzumab deruxtecan, and this was against trastuzumab emtansine. The previous study was the phase 2 trial, and in this study, they randomized previously treated HER2 positive metastatic breast cancer, and it was conducted for a period of about 2 years. And the trial involved screening 699 patients and enrolling 524. So they were randomly assigned to receive either TDXD or TDM1. So when you look at the PFS, median PFS was 4 times longer for TDXD compared with TDM1. And the overall survival was almost the same. There was not much of a significant difference, but the PFS was so significantly different. It was a 67% reduction in the risk of progression of disease. There was a 9.9-month improvement in overall survival, but that doesn't show as very significant in the end. So that it was one of the landmark trials, and that finally led to TDXD being included in the NCCN guidelines for management of breast cancer, which had progressed after TDM1. Next slide. So Destiny Breast 04 was the first trial which randomized TDXD for HER2 low MBC. So when you look at the Destiny Breast, when you look at the HER2 results, nowadays, you started getting disclaimers in the Destiny Breast 04 and 06 trials. So that was where, when you looked at the efficacy of all of these drugs in the HER2 low or the ultra low. So earlier trials were all in HER2 positive disease, and here it is in HER2 low. So this is the first randomized study for HER2 low disease, and the patients included were IHC 1+ versus IHC 2+ and ISH negative, unresectable and or metastatic breast cancer treated with 1 to 2 prior lines of chemotherapy in the metastatic setting. Hormone positive disease considered endocrine refractory, so they are no longer considered into this. They're no longer given hormonal therapy. So they were randomized 2:1 to trastuzumab deruxtecan and treatment of physician's choice. Primary endpoint being PFS. Next slide. So when you look at the progression-free survival, again, there was a huge difference, 10.1 months for TDXD versus 5.4 months for the physician's choice of treatment. Efficacy was seen in all predefined subgroups, including the HER2 1+, 2+ ISH negative and the 2+ disease. So hazard ratio being 0.51, which means there's a 49% risk reduction in progression. Next slide. So how about lower HER2 expression? So when you have an ultra low, this was Destiny Breast 06 patient population, HER2, this was done in hormone receptor positive MBC, and the HER2 status was HER2 either low, IHC 1+ or IHC 2+ ISH negative, or HER2 ultra low, that is IHC 0 with membrane staining. They should have been chemotherapy naive in the MBC setting, but they could have received something in the adjuvant setting that was allowed. Prior lines of therapy was more than 2 lines of endocrine therapy, meaning these patients have been endocrine resistant now for a long time, and targeted therapy for MBC, and 1 line for MBC and progression within less than 6 months of first-line endocrine. So they included both primary and secondary endocrine resistance for these patients. Randomized 1:1 to trastuzumab deruxtecan and treatment of physician's choice, which included capecitabine, nab-paclitaxel, and paclitaxel. Endpoints being PFS. So the 3 important differences from Destiny Breast 04. This included HER2 positive, HER2 ultra low positive breast cancer, no prior chemotherapy required, and patients with rapid progression on first-line therapy were eligible. So these were the conventionally the differences. Next slide. So when you look at the efficacy, similar results in HER2 ultra low MBC as well, and a median PFS of about 13.2 months and hazard ratio of 0.62. So TDXD demonstrated a statistically significant and clinically meaningful improvement in PFS compared with standard of care chemotherapy in HER2 low breast cancer. Whether it's HER2 low or HER2 ultra low, we've looked at 2 trials which have shown that the drug is very, very effective. Next slide. So again, the overall response rate, when you look at TDXD in various categories, activity seen in both HER2 and ultra low MBC, ultra low HER2 MBC. The waterfall plot itself shows that it is effective in both the categories. Next slide. So again, the prior endocrine therapy and CDK4/6 inhibitors, this was another subtype, which was a subset which was considered. So in this also, they found that the median PFS was 12.4 months in the TDXD arm compared with 6.6 months in the primary endocrine resistance arm. And the similar result was seen in secondary endocrine resistance, albeit the difference was much lesser, but it was still, regardless of the difference, it was still a significant progression-free survival. Next slide. So disease burden, PFS benefit was seen with TDXD, observed regardless of disease burden. Efficacy noted in patients with lower disease burden as expected. I think most of these targeted therapies work well when the disease burden is less. So they take time for a larger disease burden. So look at the plots, all of them are almost similar. Next slide. So this was again Destiny Breast 07. dose expansion subgroup interim analysis of DESTINY-Breast09 with TDXD monotherapy and TDXD plus pertuzumab. So they started combining all of these with various other HER2 targeting agents. So the DESTINY-Breast07 study is ongoing, and subgroup interim analysis from phase 3 DB09 clinical trial will give definite data on TDXD plus pertuzumab. So again, I think we are awaiting the results for this as well. Next slide. So this is the ESMO guideline for, sorry. Okay. The ESMO living guideline for hormone positive HER2 negative MBC.
Okay.
So when you have no prior therapy for MBC, a newly diagnosed patient with advanced or metastatic breast cancer, if the HER2 is low or ultra low, trastuzumab deruxtecan is one of the recommended therapies. And and chemotherapy or taxane with taxane bevacizumab or capecitabine bevacizumab if the patient has not doesn't have a HER2 ultra low disease. So this is now recommended from the ESMO MBC living guidelines, is very widely available on the internet. Next slide. So DESTINY-08, it is now investigating TDXD in combination with endocrine therapies in patients with HER2 low, hormone positive, advanced MBC. So there are several endpoints for this: safety, tolerability, adverse events, and secondary endpoints include overall response rate and PFS and duration of response. So they are trying to combine it with capivasertib, anastrozole, fulvestrant, and many other things, so that we'll find out for this might be useful for the patients with proposed ER positive and low HER2 disease. Next slide. So again, the results of these, I think it's still there, limited data. Disease progression was the leading cause of disease treatment discontinuation in both the arms. So there was 6 patients in the TDXD plus anastrozole arm and 7 patients in the TDXD plus fulvestrant arm were ongoing study treatment. So there's still way to go. We will have to see how much of safety and efficacy is there when you combine both. And as we all know, this particular subset is definitely a very challenging thing to treat. The triple positive itself is a challenge, and the when it comes to the HER2 being ultra low, I think the data are very limited, and this could also contribute to the so-called clinical endocrine resistance. Next slide. So DB09, again, this is a randomized multi-center open label phase 3 trial. HER2 positive advanced or metastatic breast cancer. They allow asymptomatic or inactive brain mets. Disease-free interval of more than 6 months from last chemotherapy. 1 prior line of endocrine therapy for MBC is permitted. So they were randomized 1:1:1 to TDXD plus placebo, TDXD plus pertuzumab, or THP. That is the standard of care in HER2 positive disease in most centers now. And the primary endpoint being PFS, secondary endpoint being OS, and there are several other secondary endpoints. Next slide. So the primary endpoint, statistically and clinically meaningful PFS benefit with trastuzumab deruxtecan and pertuzumab. So this is it is a significant shift from using only the monotherapy, but comes with its added side effects. So pertuzumab is not as safe as trastuzumab when you look at it clinically. So we'll have to look at how much of the risk is there with adverse events to prescribe such a meaningful clinical response. Next slide. So again, no, we can go to the next slide. So this is the hormone positive general guideline, so whenever you have, where do you give TDXD? So that is the only thing. Whenever you have patients who have primary or secondary endocrine resistance and they have a HER2 ultra low or low, that is the time when you consider them for TDXD. And if they fail, then there are other options like sacituzumab govitecan, datopotamab deruxtecan. All of the other second-line options are always available. So that is very important to identify at some point where the endocrine resistance happens. We have to consider doing a repeat biopsy and finding out if the HER2 is ultra low or low status. Next slide. So there are newer agents and novel agents are there. We have patritumab deruxtecan. We have BB1701. We have disitamab vedotin. So many of them have actually come up now. Many of them are topoisomerase inhibitors, or most of them act on the microtubular pathway, the payload as such. So we will be looking at more agents to see in future. Next slide. So treatment-related adverse events, as for any ADCs, it's almost like more than 90% of the it is very similar. Most of the ADCs have very similar adverse events. And next slide. You have nausea, fatigue, and many of these drug-related side effects. I think you'll be looking at all of your antibody drug conjugates, including the TDM one, which was given earlier. So you have nausea, fatigue, alopecia, increased transaminases, diarrhea could be there, leukopenia could be there. So severe fatigue can be there. That's one drug side effects that we could look at very importantly. And this was from the DESTINY-Breast03 trial. Next slide. So again, this is again a slide to tell how, to manage the adverse events whenever there are grade 2, grade 3, and grade 4. For grade 1 events, we do not stop therapy. We just give symptomatic treatment. There is no need for dose reduction. For grade 2 toxicity, we hold therapy for 3 days. If the drug-related adverse event doesn't come down within 24 to 48 hours, or actually up to 72 hours in some cases, then we go for a dose reduction in such patient, which can be up to 20%. If the patient has a grade 3 toxicity, we have to definitely reduce the dose for these patients. We don't wait for recovery. We have to reduce the dose from the next cycle. And grade 4 toxicity, we stop. In the only exception to that being the ILD, which occurs because of the trastuzumab deruxtecan. One of the most dreaded adverse events of TDXD, the Enhertu, is the ILD or pneumonitis that happens. And in such cases, when the patient has a grade 1 adverse event, we prefer to reduce the dose, and whenever there is a grade 2 adverse event, we prefer to stop. So it is very important that we identify the toxicity early. Next slide. So drug-induced interstitial lung disease and left ventricular dysfunction are adverse events of special interest. They're extremely rare events, but when they happen very badly. So we should be on guard for any of these symptoms. I would recommend consulting a thoracic physician at every visit and finding out if there is any need for a pulmonary function test or a HRCT scan to find out if they are symptomatic. Clinical lung screening should be done for all patients on trastuzumab deruxtecan. Ejection fraction measurement should be done at least once in 2 to 3 months for these patients. Otherwise, we will never be able to understand the cardiac adverse events of such patients. Next slide. So these are the 5 S's: screen, scan, synergy, suspend treatment, and steroids. So ILD can be easily handled. A grade 1 ILD, when it switches to grade 2, then we look at all of this. Steroids might be the cornerstone for treating ILD induced by TDXD, and the toxicity has to be defining the dosage of the drug to be given. Next slide. So again, this is a slide on ILD. So monitor for suspected ILD, interrupt trastuzumab deruxtecan, high resolution CT, pulmonologist consultation, blood culture, CBC, rule out other causes of breathlessness and interstitial lung disease, including viral pneumonitis. All ILD events, regardless of severity or seriousness, should be followed until resolution, including after drug discontinuation. So in contrast to most of the adverse events, whenever the patient has grade 2 or symptomatic ILD, we permanently discontinue trastuzumab deruxtecan. We do not re-challenge after a reduced dose. We do not give them any form of therapy after they develop a grade 2 event. For a grade 1 event, we can interrupt, give steroids, and once they become better, you can reduce the dose and re-challenge. But the threshold for stopping the drug is very low with TDXD. Next slide. So there are, again, these novel antibody conjugates which I had mentioned, and there are others in very early phase of disease. So we'll be looking at what they're going to have in the future. Next slide. So trastuzumab deruxtecan is currently approved for HER2-low metastatic breast cancer, both hormone positive and triple negative, after 1 prior line of chemotherapy. It demonstrated activity in earlier lines as well as HER2 ultra-low MBC. When you look at the previous slides, the drug was effective in all subtypes of HER2. Sacituzumab govitecan approved for metastatic hormone receptor positive breast cancer after 2 lines of prior systemic therapy, presently not available widely. So we will definitely prefer to use trastuzumab deruxtecan if the patient is eligible. There are other multiple novel HER2 ADCs in development to target antigens overexpressed in MBC. So we would look at a newer approach to targeting HER2 positive HER2 with bispecific antibodies, low toxicity with marked efficacy in HER2 positive disease, early approvals in highly resistant disease, expanding to HER2 low disease, and suspect efficacy as well in HER2 mutant disease. So we are not looking at that right now in breast cancer. HER2 mutation is important in lung, we agree, but we are not looking at HER2 mutation as of now. So it is how important it is, we are not able to say right now. With a small data set, it is impossible to know what the contribution of endocrine therapy is to the efficacy of TDXT. We saw that the trial was a failure. Many of the patients had progressed. So we have to look at how this interacts with the endocrine therapy in future. So next slide. I think that's all. I think that's it. Okay. Thank you very much. My experience with ENHER2 hasn't been really great. We've had a couple of a few patients, not a couple. We have had a few patients who have responded, and most patients who have not responded. So, and they were used after the first line failure, meaning they have become metastatic after the use in adjuvant therapy. Current recommendation is to use ENHER2 before Kadcyla, that is TDM1. The efficacy is more. When you look at the Destiny Breast trial that compared head-on, it says that the drug can be used initially before the TDM1. We agree that TDM1 is much less expensive than ENHER2 today, but I think going by science, we should be re-challenging. ILD remains a concern and a fear, but I think it's a rare event, so we should just be clinically watchful, else it should not become a very big setback to using ENHER2 in the future. Thank you very much. I'm looking forward to the talk by the pathologist as well to enrich our knowledge on ENHER2 and on IHC in HER2 positive disease. Thank you very much.
Thank you, ma'am. Thank you so much for the comprehensive presentation and valuable insights. So now we move on to our first panel discussion on the ER treatment conundrum in the wake of HER2 low and ultra low targets. The session will be moderated by Dr. Satyasadan Sarangi, Consultant Medical Oncology, BLK Max Super Specialty Hospital, New Delhi. Joining him on the panel are Dr. Uma Dangi, Senior Consultant Medical Oncology, Kolikenbed Dhirubhai Ambani Hospital, Mumbai, Dr. Lal Mohan Sai, Medical Oncologist, Acharya Harihar Regional Cancer Center, Cuttack. Dr. Akash Ambadasevachan, Consultant Medical Oncologist, Mumbai Oncocare Center. Over to you, Dr. Sarangi and panelists.
So, am I audible?
Yes,
sir.
Okay. So, good evening, everyone. First of all, I'd like to thank the program director for giving me this opportunity. And I would also like to welcome all my panelists, Dr. Lal Mohan, Dr. Akshay, and Dr. Uma Dangi. So, do I have all the three panelists?
So Uma
can
Dangi
see
ma'am has
Dr.
just disconnected. Ma'am will be joining in a couple of minutes.
Okay. So, I think we can start, right?
Yes, sir. I'm fine.
Okay. So this panel discussion is regarding a case of a 50-year-old postmenopausal female with a right-sided CA breast. On biopsy, it was an IDC grade 2, ER's PR positive, and a HER2 ISC 0 case. So she was initially, to begin with, a T2N0M0 disease, was treated with the standard treatment of taxanes and cyclophosphamide, surgery, radiation, followed by adjuvant letrozole-based therapy. Germline HbOc panel at that time was negative, and after that, she was lost to follow-up. So there was a gap of almost 5 years. Then in 2022, the same patients presented to us with a history of a severe back pain. So hence an MRI was ordered, and it was suggestive of bone metastasis. So my question to, I think Uma ma'am has joined. So my question to Uma ma'am is, ma'am, at this point of time, what all investigation would you require to go forward?
I'm sorry, I just joined. Can you just go back to the case? I'm sorry, I missed the first slide.
Sure. So ma'am, it's a case of 50-year-old postmenopausal lady, initially treated with standard treatment, and was put on adjuvant letrozole. Germline HbOc is negative, and she was lost to follow-up for 5 years. She was ER/PR positive, HER2 negative 0, ISC 0 to begin with. And then after 5 years, she presented with severe back pain, and the MRI was suggestive of bone metastasis.
Okay. So here, and she was off therapy now, na, since for last few years, or she was just lost to follow-up. Was she taking
She was
treatment?
lost to follow. She was lost to follow.
Okay.
Let's
So
assume
I
she
would
was.
want to do obviously a thorough clinical examination would be here to see if there is anything which is clinically biopsyable, which is easier because we don't really want to do a bone met biopsy because of the processing, which may actually give a wrong IHC result. So if not, then would do a PET CT to see if there is any other easier way to do a tissue biopsy in her case. That would be my
So-
investigation of choice. If at all there is no tissue which can be done, then we would think of a liquid biopsy. But right now, I would really want to know whether this is actually the bone mets are really the breast which is coming back or something else.
So very pertinent point, ma'am. So like ma'am said, we ordered a PET CT scan for this patient, and it revealed a pleural-based soft tissue density mass lesion, and multiple liver soils and the lytic lesions with the partial collapse of L1 vertebra. So here we can see the PET CT revealed that there were other lesions also other than the bone lesions. So now my question to Dr. Akshay. Akshay sir, at this point of time, what would be your next point of investigation? Hello? Hello? Am I audible?
Yeah, you are audible.
Yeah. So I think Dr. Akshay is not there. So I will ask Dr. Lalmohan. Dr. Lalmohan, what would be your next line of investigation or management for this patient after this PET
Yes, sir.
CT?
So we'll do the biopsy from the metastatic sites, maybe from the liver lesion. So it is a large lesion. So and we go for the ISC of that. And apart from that, we'll do all the other hematological investigation and cardiological investigations of this patient.
Sir, can you specify which all IC marker would you like to see at this point of time?
We'll definitely repeat all the tests ER, PR, HER2, and Ki-67.
So that we did a rebiopsy from liver was done, and it again showed a ER positive, PR positive. This time the HER2 was labeled as 1+, but it was FISH negative. Ki-67 was 60 to 70%, and GETA3 was positive. So I think it basically showed that the lesion was originating from the earlier breast CA, and the ISC status was more or less same, but the HER2 was changed from 0 to 1. So my next question to Dr. Akshay is there or not? I don't think Dr. Akshay is here. So Uma ma'am, my next question to is, so why do we do this rebiopsy? So do you feel that there is a discordance rate or there is a change in HER2 status from earlier to before? And if yes, then what is the percentage as per your clinical practice?
So yeah, definitely there is data also. Around maybe 5 to 10% patients may actually change their HER2 status, and we would definitely do a rebiopsy, particularly in her case because she's been like for 4 years she was okay. So firstly, the biopsy is to confirm the primary, and secondly, of course, we want to run the markers and see. I don't really see the point of rechecking the HER2 on earlier blocks because it irrespective of those, if the HER2 comes plus here, we will obviously treat it like a HER2 low disease. So yeah, so definitely I do rebiopsy most of my patients. I biopsy almost every patient who relapses. So that's how because we really need to understand the biology of the recurrence.
So the data also suggests some like there is a discordance rate from the primary to metastatic site in almost 40% of patients. Similarly, HER2 low patients can go to HER2 zero in 20% of patients. So there is this dynamic expression of HER2 low that we see in the advanced stage patients. So this I think we have discussed. So the discordant rate as of now is as per various studies is hovering around 20 to 25%. And these are some strategy by which we can optimize the performance in the diagnostic process for interpretation and having consistency across the spectrum of HER2 expression is by doing is basically depending upon the type of biopsy, the handling of the tissue, the cold ischemic time, and the type of assay that we use. So I think HER2 ISC status, I think all of us know that what is ISC, HER2 1 plus or 2 plus. So just to reiterate, a weak to moderate complete membranous staining in less than 10%, or a strong incomplete membranous staining in more than 10%, or a barely perceptible staining in more than 10% is categorized as 1 plus or 2 plus. And the HER2 1 plus or 0 is, since it's a new entity called HER2 low, which is there nowadays, it is called barely perceptible staining in less than 10% of patients.
That's HER2 ultra low, right? Yeah.
Yes, HER2 ultra low, sorry. So now coming to, should we plan the treatment, like ma'am said, if there is a change in the HER2 status, or in this case that we see, if it would have been a HER2 3 plus, so should we follow the new biopsy? Should we follow the old biopsy? So I would like a comment from both Dr. Uma ma'am as well as Dr. Lalmohan. Do you agree with the statement that I'm showing on my slide? Dr. Uma ma'am?
So, so if it is clearly HER2 plus 3 or a FISH positive this time, I would treat
Yes.
it as a HER2 positive, because I know this time it is the driver. So I would definitely consider a dual anti-HER2 therapy with chemotherapy. If it is HER2 1 plus or low or ultra low, like we talk about, but then I would really want to understand what kind of endocrine treatment, because if you see the indications for the HER2 low, if patient had, as she was lost to follow up, if she has been non-compliant, and if it has been more than 2 years since she stopped therapy, then she's likely to be still endocrine sensitive. And here is where I would want to give her a combination of CDK4/6 with endocrine therapy, like aromatase inhibitor, or and then see the response and then take a call.
Any
Yeah,
point?
yes, Satya, I agree with the Dr. Uma. She rightly said the treatment protocol of this patient.
So the take-home message for the residents who have joined with us is, if you do a rebiopsy and if there is change in the receptor status, where you can offer them a targeted therapy, especially in the HER2 3 plus setting, then we generally try to treat the patient according to that driver mutations. But if it is a HER2 low, then we have to go the old the ERPR positive HER2 negative way. I think this has been discussed. Now coming back to the case, so she was, for this patient, since it was an HER2 1 plus disease, we decided to start her on abemaciclib plus a fulvestrant based regimen. Now, Uma ma'am, I would like to ask you, let's assume that this patient was on letrozole versus this patient has discontinued letrozole. So do you agree with this regimen, or would you like to add on anastrozole instead of fulvestrant, based upon the different case scenarios that I asked?
So if she was progressing on letrozole, then I would agree with what you have done here, giving fulvestrant with abemaciclib. If she had been off more than 12 months, then I think giving anastrozole, letrozole, or even exemestane at this point is okay with the CDK4/6 inhibitor.
And do you differ with this regimen? Would you like to add some other CDK4/6 inhibitor or other AI?
No, so if it is, I think a choice of CDK4/6 inhibitor is mainly depending upon our comfort, because what we are used to, and secondly, obviously, the toxicity profile more than the survival. This has been discussed many times in many conferences, and that's the consensus that it depends upon what comorbidities the patient has. So somebody who I expect, and the cost, of course, of therapy, because we know that palbociclib now, a lot of generics are available. So, depending upon that will be the choice of CDK4/6, not based on anything else. So any choice is okay. Abemaciclib, maybe because, it's a continuous drug, there's no gap. So, compliance may be a little better. But otherwise, there is no particular reason. If patient develops, if the patient was already on a CDK4/6, then here I would have liked to do that ESR1 and all those other molecular tests as well. Can you hear me? I mean, I can't hear you.
Hello, am I audible?
Yes, audible. Or
Hello?
you are audible.
Yeah. So, Dr. Lalmohan, I wanted to know from you, do you agree with this regimen or do you have something else in your mind for this patient at this point of time?
Yes, I agree. But if patient has already progressed on only letrozole, so we may consider aromatase inhibitor with any CDK4/6 inhibitor, either ribociclib. Or you have already given the second line. We usually give CDK4/6 with fulvestrant in the second line treatment in a metastatic setting.
Okay. So, going forward, 8 months down the line, there was again a progressive disease. Now, before what we did, that's a separate story. I would like to again ask my panelists. So, if there is a progression on CDK4/6 plus AI, so what other investigation you require before proceeding forward, or you can just directly go forward to a chemotherapy regimen? What's your take on this? At this point of time, what should have been done?
Sorry, so patient has progressed on a CDK4/6 inhibitor, you're saying?
Yes. So patient progressed on abemaciclib plus fulvestrant. And here we are
Okay.
assuming the patient progressed on letrozole initially.
No. So, no, I'm sorry. I'm confused. So, the
Let me just
patient,
read.
the question is regarding progression on letrozole or progression on abema with fulvestrant?
Ma'am, patient first received letrozole. Then on letrozole, she developed bone metastasis. We gave her abemaciclib plus fulvestrant.
Okay.
Now here there is a progression.
Okay, so now if there is progression, definitely one thing we want to know is this, because this is looking like a more aggressive disease. It's not the one that it's rapidly progressing. So obviously here, because she's a HER2 low, is some point in time we will be discussing the option of TDXD. But here also we would want to do the like I said earlier, the ESR1, PTEN, etc., to see whether there is any other targetable mutation which we can use the newer drugs. Of course, I'm not sure if they're available here in India right now, but yes, if there is a strong mutation, then we can obviously try it for those particular targeted drug and maybe reserve TDXD later.
So what I get from you is that for at least for initial 2 lines, you would like to stick to a hormone-based therapy regimens rather than shifting to anti-HER2 based therapy. Okay.
Yeah.
Okay. So for this patient, since it was 2023, we decided to start her with capecitabine, and there was progression with newer bone lesions within the 3 months on capecitabine. So now the patient has progressed on 1 line of hormonal therapy and 1 line of chemotherapy. And let us assume an NGS is ordered and 3CA is wild type, PTEN is non-mutated, ESR1 is non-mutated. Now what to do? Dr. Lalmohan.
Yes, because it is a HER2 1+. So we consider after getting the DB04 trial, it is a practice-changing trial. So it is a HER2 low patients. Here PR positive and HER2 low patients. So we consider the DB04 regimen like TDXD every 3 weekly. We can consider for this patient.
Okay. So like sir said, the DB04, we have the data in the HR positive subset as well as in all the patient subset. And in both the subsets, the hazard ratio is near about 0.50. And both the subset of patients are doing quite well with TDXD as compared to the physician's chemotherapy of choice. Also, regarding the overall survival, here also we can see there is a significant difference between the Kaplan-Meier curves in both the ITT population as well as in the hormone receptor positive cohort. Now then, there's this another question because I really feel in the ER/PR positive and HER2 negative or HER2 low or ultra low, whatever you want to say, So initially, 10 years back, it was very simple. We used to give an AI, we used to give fulvestrant, we used to go the Bolero regimen way, and we used to give chemotherapy. But now with the advent of this bispecific antibodies, antibody drug conjugates, there is another antibody drug conjugate that is making its way is sacituzumab govitecan. So although I accept that this drug is yet not available in India, but I would like to ask my panelists, what's your take on this drug for the ER/PR positive and HER2 negative subset? Dr. Uma, ma'am.
So I'll tell you, I don't have any first-hand experience of using the drug. I'll confess that. But here, if there is HER2 low, now even TDX, you're really tempted to use TDXT, given the data and now with the DB06 also. So, I mean, you really want to use this drug earlier so that you give the best benefit to the patient. Yeah, after that, whether to give a second ADC or not is still, there are trials which are trying to look at whether you can give one ADC after the other, but that's something that I don't think we have an answer to yet. But definitely, I would prefer to use a TDXD in a HER2 low, given the data. If it is triple negative, yes, then where you might want to think of, or sorry, if it is a HER2 negative, yeah, that's where we would probably want to give sacituzumab govitecan.
On this?
Sorry, I can't hear you.
Hello? Hello?
Yeah,
Yeah.
I can hear you now.
So I was asking Dr. Lalmohn, any take on this, sir?
Basically, both has a survival benefit in metastatic setting breast cancer with HER2 low positive, both TDXD and sacituzumab govitecan. But there is no data yet. We can tell that which one should be used first and which one should be not. So still, I have no idea which one to be used first.
So the take-home message here is, considering the lack of data and the lack of experience and the lack of availability of sacituzumab govitecan, PDXT as of now takes preference over SG. So this is just the data to support both the drugs. So we have the DB04 data for the use of PDXT in the second line plus setting with physician chemotherapy of choice. Here the hazard ratio is 0.51, and if you see the TROPiCS-02 data, it's the third line of plus for sacituzumab govitecan versus chemotherapy, and here also the hazard ratio is around 0.65. Okay, so another question to my panelist. Let's assume for this patient, if after giving abemaciclib and fulvestrant, or the patient did well for 2 years, so would you re-challenge with another CDK4/6 with another AI, or would you won't accept this pathway ever? Dr. Uma, ma'am.
Yeah, so there are studies which have looked at continuing CDK4/6 inhibitors on progression, and they have shown some promising results. But given if it is HER2 low, then when you have such a good drug, then why would you? Then I don't want to continue it, because obviously you can't compare cross trials, but the hazard ratios for the TDXD are really, really impressive. And the long term, I mean, we have good survival data, so I would want to change. I would not continue with the same.
Lalmohn, let's say patient cannot TDXT, and initially there was a good response on CDK4/6 inhibitor. If there is a good DFS or a good DFI?
Basically, still there are no data to re-challenge with CDK4/6 inhibitor. So I will not re-challenge with CDK4/6 inhibitor in these patients.
Okay, so the data which we have is very conflicting as of now on CDK4/6 inhibitors, with some trial like maintain trial showing benefit of 3 months, whereas a base trial did not. So it really depends on case-to-case basis. For a ER/PR positive HER2 negative, if the NGS is suggesting of some kind of mutations with ESR1, PIK3CA or PTEN, you can really go down that way. If everything is wild and patient is affording, then TDXT seems to be the way forward. But if let's say there is financial issues, the patient has received palbociclib in the first line, and he or she has remained well for 12 months or more, then there is some evidence like this phase 2 data that I suggest that you can re-challenge with another CDK4/6 for that particular subset of patient. Then there is another conundrum called germline BRCA positive. Let's say the germ patient is positive for germline BRCA. So do your sequencing change anyhow, Uma ma'am? Do you like to give a PARP inhibitor upfront, or would you like to reserve that for 5th line or 4th line setting?
So I would want to give the PARP inhibitor earlier, because you know that the PARP given earlier has better impact than giving it in later lines of therapy. So definitely, if she is BRCA germline positive, then I would want to use a PARP inhibitor upfront rather than later.
Dr. Lalmohan?
Yes, if BRCA is positive from the baseline, so we can give it during the adjuvant therapy only. But in metastatic setting, sequencing, it is difficult. I cannot say when to use, basically.
Okay, again, we have this sequencing conundrum. Like, should we use upfront? Should we use at later lines of time? Different people have different thoughts. I agree with Uma ma'am that yes, whatever benefit we have seen for BRCA is usually, at least in the TNBC subset where there is a strong data, to use it in the frontline setting. So there we have seen earlier the better. So we have this Olympiad and the EMBARCA study, which have tried olaparib and talazoparib with the treatment physician with the physician treatment of choice. And in both the in both the studies, here you can see that there is a 3 to 4 months PFS benefit with this PARP. So this current knowledge gap still exists. Like, will the HER2 IC levels matter in the end for TDXD? I was just looking at the DB trial data series. Now we are talking about DB11 of bringing TDXD in the frontline setting. Then there is DB15 where they are trying TDXD in HER2-0 also. So do this HER2 will matter in future for if we are using TDXD if those trials are positive? And in clinical practice, should we give maintenance endocrine therapy for HER2-low HR positive if TDXD is stopped due to toxicity? So Uma ma'am, I would like your opinion on this. Uma ma'am, am I audible?
Yeah, Can you hear me now? I was on mute. Yeah, sorry. So you want to ask about maintenance endocrine therapy in
Yes.
metastatic disease, right?
Yes. If it's a HR positive, HER2.
I would give it. I don't know what it adds, but I will give it. If it is positive and if she's still endocrine sensitive, then I would probably I would give endocrine therapy as well. So I know there is no data whether yes or no, but I will give.
So not per se data related to this, but I think recently there was a meta-analysis or a systematic review. Like many people were saying that we should treat the ER low, that is between 1 to 10% as TNBC. But the recent analysis showed that even if it is positive, whatever HR is positive, we should always try and give hormonal therapy for whatever benefit it would add. Dr. Lalmohan, do you agree with
You were talking about HER2 low or HR low? I thought you were talking about.
No, ma'am. I am saying my initial question was for HR positive, HER2 low.
Okay.
But the rationale for using endocrine therapy, even if it is ER, like there is a recent paper which was looking at that for ER 1 to 10 and versus more than 10. So many people are saying that ER 1 to 10 should be treated as TNBC. If it's a HR, let's say ER is just 1% positive, PR negative, HER2 negative. So many people are trying to see that the behavior is like TNBC, we should treat like TNBC. But a recent paper on this has suggested that even it is ER is more than 1%, 2%, 3%, so hormone therapy always benefits. So we can extrapolate that data and give here for the maintenance.
It's a conundrum for another panel discussion.
I think the TNBC will be coming up after this. So Dr. Lalmohan, do you agree with what Uma ma'am said, or do you have a difference in opinion here?
Yeah, we have a trial, the DB08 trial, where they have seen that TDST versus TDST with anastrozole, TDST alone has a better overall response rate as compared to TDST with anastrozole. So after toxicity, of TDSD. So we may stop the TDSD and we can continue anastrozole because we need a continuous suppression of the estrogen receptor pathway. So that is, I think it will be better to continuously suppress with some form of treatment, like other like newer modality of estrogen receptor degrader or down regulator drugs. Okay. And HER2 IC level is a matters. It matters. We should better in a quantify and qualify in a better way to appropriately give this antibody drug conjugate in a metastatic HER2 low patients or HER2 ultra low group of patients.
Okay, so with this, I would like to thank my panelists and for their wonderful opinions and their expert comments on this some key controversial issues. And I would like to hand over the stage to the organizers. Thank you.
Thank you.
Thank you. Thank you.
Thank you to all the panelists for that engaging and thought-provoking discussion. Next, we move on to our talk on revisiting HER2 status in HER2 low and ultra low era pathology. It's my pleasure to welcome Dr. Nirmalaya Banerjee, oncopathologist, consultant and lead histopathologist at CK Birla Hospitals, Kolkata, to provide us with deeper understanding. Sir, over to you, please.
So thank you very much. So today we are going to discuss about the, am I audible?
Yes, sir.
Okay. So today my screen is visible.
Yes, sir.
So today we are going to discuss about the when to report HER2 ultra low, what clinical implications does it mean, and what are the protocols we used to follow in the histopathology lab. What is the log protocol? How should be the formalin and the pre-analytical factors regulate this HER2 status? And of course, the most important part, the quality control of the reporting. And then we have to be updated about the recent ASCO CAP guideline. And we must mention in the report that what the ASCO CAP is saying as far as the new HER2 classification is concerned. So to start with, I would like to start with the Destiny-04 trial. So it is the, you can say like it's a renaissance as far as the HER2 status is concerned. So in Destiny-04 trial, it literally breaks the typical binary of HER2 low and sorry, it's not HER2 low, the HER2 positive, and typical negative. In between, there is a third space. The Destiny trial has created a third space, which is neither a typical HER2 positive or not a typical negative, which is HER2 low. So this HER2 low has created a lot of influence in the clinical part. So as my previous speakers have described it, that in the Destiny-06 trial, which is after the Destiny-04 trial, the efficacy of the TDXD is studied in the hormone receptor positive, HER2 low and ultra low, and chemotherapy naive metastatic breast cancer patients as compared against the physician's choice with a single agent chemotherapy. So what we have seen is the previously 60 to 65% patients which were categorized as HER2 low and the rest of the 35 patients which were typically reported as HER2 negative can now be divided as HER2 null and HER2 ultra low. So all the discussions, the crux is when to call it as ultra low, when to call it as a low, because the change in the reporting pattern means a lot to the clinicians. So you can see in this second bracket, the right hand side, we have mentioned that these are the candidates for the TDXD or antibody drug conjugate. So now you understand that a single report can lead to a lot of clinical significance. So with this knowledge, let us see the traditional HER2 reporting, and we have to know the latest reporting protocol. Now, in the traditional HER2 stratifications, we used to report like HER2 positive, HER2 negative, and the equivocal. followed by the FISH testing. Now, currently, what in the 2023, we came to know that yes, we have to report HER2 low or HER2 1 plus, which can be reported as HER2 low. In the evolving landscape, in the later part of the 2024 and 2025, we are a bit updated and we are calling this 0 plus category, which is in between HER2 null and in between the 1 plus to null. This space is the HER2 ultra low. So in the traditional practice, HER2 low we used to say as defined as immunohistochemistry wise 1 plus on IHC or 2 plus with FISH after the FISH positivity. So HER2 ultra low expression is defined as where the less than 10% of the infiltrating cells, not the DCIS component, is showing incomplete and faint or weak membranous positivity. So now you can understand to report HER2 ultra low, one must spend time in the high power magnification. So in the majority of the hormone receptor positive and HER2 negative in metastatic breast carcinoma, where HER2 positivity we have seen approximately 20% and the triple negative group stands for the 15%. So rest has been reported as HER2 negative. Again, we call it negative means 0 or HER2 null, 1 plus, which is now as low positive, or 2 plus FISH negative. So this 65% was the target. So in this 65% group, you can well see that this HER2 ultra low category with 0 plus with membranous staining stands about 20 to 25%. So out of 65%, this 25% came to be ultra low. And the rest of the patients where this is hormone receptor positive and HER2 low stands for 60 to 65%. And rest of the patients which are completely zero, we call it HER2 null. So there are two big giants in the as far as the reporting standard is concerned. One is the ESMO, one is the ASCO-CAP. Now both they have provided the guideline that if there is a bit amount of positivity in the HER2 reporting, one must categorize it as a either HER2 low or HER2 ultra low. Now when to call it? If in a day-to-day practice, if a histopathologist is seeing that there is a faint membranous staining of less than 10%, which is a bit of arbitrary, I must say, there is no strict criteria of 10%. If it is less than 10%, then according to the previous classification 20818 guideline, it was reported as HER2 negative or HER2 0. Now in ESMO 2023, they now call it HER2 0 plus or HER2 ultra low. And the incomplete staining with more than 10% of invasive tumor component, which was previously again reported as HER2 negative, now we say it as HER2 low in spite of FISH negativity. This is more important, I think, that even if your FISH test is negative and you are getting more than 10% of the tumor cell, you can report it still on your IHC report, it is HER2 low. And of course, weak to moderate staining, which is more than 10%, moderate staining, of course, FISH positivity. Previous guideline also it was HER2 positive, and in ESMO 2023 guideline, it was still reported as positive, and rest of the criteria remains the same. So now the role of pathologist or the histopathologist, the importance of the histopathology reporting has increased quite a bit, because examining the HER2 IHC slide according to the guideline or the scoring criteria has to be mentioned, and it has to be formulated within each of the histopathology lab who is reporting this HER2. Now, the examination, as I have said earlier, must be seen and one must spend time with 40x, especially when you are discriminating between 0 to 1 plus staining. And considering the second pathologist review when the results are close to 0 or 1, or That means whether you are dealing with a null or a 1 plus or 0 plus, that should be the threshold. I mean the 10% cutoff value. Of course, there are inter-observer variations in between the reporting, but still one must consider a second pathologist in the same department. Using controls with a range of protein expression, including 1 plus, to help and ensure has an appropriate limit of detection, and careful attention of the pre-analytical conditions of the breast cancer tissue samples, which I will be covering later part of my discussions, play an immense role in both primary as well as the lymph nodal metastatic sites. Now come to the directly interpretation part of the HER2. Now in this I must mention that please, when you are using the Ventana platform or the Roche diagnostics, we must buy 4B5 monoclonal antibody. So this is one of the important clone. Apart from that, you can also buy A0485, which is also available, but still I will prefer the 4B5 clone, which is usually available in the market, and you can easily apply into your histopathology lab. And there are in the CAP guideline, there are so many clones which they have recommended. Apart from that, any other clone is not accepted. Of course, if you are using BondMax on Leica, you can use CB11. CB11 is the second most commonly available antibody clone. But in my lab, I prefer 4B5. I use 4B5 regular basis. And they are typically optimized for HER2 positive breast cancers only, not in other scenarios where HER2 testings are done, like in the pancreatobiliary and in the genitourinary systems. In the endometrial carcinoma, there is no strict criteria that these clones should be used. But later on, I mean, the protocols are changing. They will come with some guideline where they will fix the clone. But right now, these are for the breast tumors only. And further optimization of the standalone antibodies may be required, and laboratories are responsible for this assessment. Now, you can easily see the circumferential and membranous staining that is complete. I must say it is intense, it is visible, it is conspicuous, and is covering more than 10% tumor cells. You must label it as HER2 3 plus, no other left and right. You must mention your clinician that I am getting 3 plus positivity. So then and there they will start chemotherapy against HER2. In 2 plus, pathologists play a very crucial role because you have to write at the bottom of your report that FISH testing is mandatory because weak to moderate staining, more than 10% cells are there. And this moderate word is extremely important. Moment you say it is moderate, it falls under category of 2 plus. If you say that is an incomplete and membranous staining, remember this word, it is membranous, it is not cytoplasmic blush. It has to be incomplete and it has to be linear, membranous, and barely perceptible in more than 10% cells. You must label it as score 1 plus, which is, according to the latest guideline, is the low positive HER2, and it is the candidate of TDXD. And of course, no staining, approximately at least not even a single cell is positive, you must score it as HER2 0, and according to the latest guideline, you should label it as HER2 null. So as we discuss further, we get to know that at least 12,000 receptors should be there to call it as a positive. So if it is a less than 12,000 receptor, we call it as HER2 null. Now, difference between the staining pattern and between 0 and 1 plus, as I have said earlier, is very much subtle. So if you are getting 1 plus or low positive, you must check your slides in the 40x. If it is 2 plus you are getting, you have to cross check it under 10 to 20x. And if you are 3 plus, you are very confident, you can make your diagnosis under the scanner, or you might say low power or 4x. So this is the standard guideline, and this is how it looks like under the microscope. And this is the 40x magnification view. You can see maybe needed. This is maybe needed, or it is needed, at least I do, to call it as HER2 low or HER2 0 or 1 plus in the 40x when the discrimination is necessary. So I must say that identifying HER2 ultra low breast cancer is more challenging for the pathologist, because what I have seen in my lab, that outside blocks becomes difficult. It becomes a nightmare sometimes. If in outside block you are getting HER2 ultra low or HER2 low, you don't know the which protocol they have followed to fix the slides, to fix the specimen. The individual differences in the color perception is a major problem sometimes, and that is why the automations is coming. It will remove all the color perceptions and confusion with the potential cytoplasmic and non-specific training. But again, the automations also has some limitations. However, I will suggest the pathologists need to have accurately select the appropriate fields. So before you hand over the slide or the block to your technicians, you must mention that these is the area, or these are the areas where you are getting maximum cellularity. It also applies for the IHC as well as the FISH testing. And whenever you are getting a faint staining, please show the slide to your fellow colleagues and examine under 40x. It matters a lot to the patient, hence for the clinicians. Now, how to report? The next important questions, that how to report it. Now, the results and report may influence the clinician's decisions making. So the consistency of the data elements, improved completeness and accuracy and ease of reporting, and the template assists the pathologist in providing clinically relevant information when reporting biomarker tests results. However, all the labs in our country which I have seen, they do not follow the typical template pattern. Each lab and each hospital I have seen, they have their own protocols. But whatever be the protocol, one must mention that how long it was there in the formalin, or what I mean to say in short, the ASCO cap footnote has to be there. And the synoptic reporting is a process for specific pathological data, as we all know, in a structural format as opposed to narrative style. Now nobody wants to read the lot of straight lines in your report. So make it synoptic so that easily readable, easily understandable to the clinicians, because a report is a communication between the two doctors, be it pathologists, be it clinicians. So it has to be understandable. And the CAP has published examples of reporting, like consideration of the HER2 pathology reporting, that how to select the slides and when to report, and the classification of the HER2 scoring. So we must visit the ASCO CAP guideline while reporting it in a standard histopathology lab. So the footnote must mention that patients with the breast cancer with HER2 IHC 3 plus and 2 plus may be eligible. This maybe is important for several therapies that disrupt the HER2 signaling pathway. And invasive breast cancer tests which are HER2 negative are more specifically considered HER2 negative for protein overexpression or gene amplification, since non-overexpressed level of the HER2 protein may be present in these cases. So this is more important, that the last line, the overexpression and gene amplification, since overexpressed levels of the HER2 protein may be present in these cases. And the patients with breast cancer that are HER2 1 plus and 2 plus with each non-amplified may be eligible for the treatment for the targeted and non-amplified levels of HER2 expression for cytotoxic drug delivery. So high HC 0 results do not result in eligibility currently. So one must mention this report should be there. So these lines should be mentioned in the report. Now, according to the test criteria, now the purpose is when to test. The expression of HER2, as you all know, is dynamic. So we have seen that in case of primary versus residual breast cancer, some portions of the HER2 ultra low or HER2 low has been reported in the residual breast cancer, approximately 14.8%. And on the other hand, another study in patients with the matched primary and recurrent stage 4 breast cancer samples found that 15% of the cases switched from HER2 0 to HER2 low, while 14% of the cases switched from HER2 low to HER2 null. So therefore, the expression of HER2 is very much dynamic. And among patients with a primary HER2 negative, defined as 0, 1 plus or 2 plus and FIS negative tumor, the switching rate of HER2 status was higher. This is extremely important. So patients with a HER2 negative, their switching status of HER2 was higher in in hormone receptor positive and HER2 negative versus TNBC cases. So we must remember these things. And retesting of the HER2 expression in a metastatic setting is a key for expanding treatment opportunities in this. We will never know. So in case of metastatic setting, one must do the retesting of the HER2, especially the HER2 when it has been done in some other lab or in some other hospitals. The metastatic site is extremely important. One must be aware that you might get HER2 low or HER2 ultra low. So there are several factors also that suggest that importance of the retesting. One of the important factors is if the primary tumor is heterogeneous. Yes, it can be for the receptor expressions, the nature of the HER2 is also heterogeneous. And when the receptor status of the primary tumor is unknown, and if the metastatic evolution of the metastatic clone is unusual as compared with the tumor characters, which also might happen. And of course, the new therapies, if available, and the initial test was performed more than 10 years, so one must ignore if it is done more than 10 years. And of course, the infrastructural support or the financial supports are there. So these are the factors which can regulate the retesting of the HER2 in a metastatic setting. So as per DB06 trial, in the subset analysis, efficacy of the DDXG and the HER2, similarly irrespective of the tumor locations and the sample collection types. So if we see the tumor which are in the primary site, there are a number of, out of 93, there are 55 patients which are from the primary, and out of 343, there are 214 was from the metastatic site, and at least one IHC report with discrete IHC scores and percentage of the cells stained is required in case of metastatic setting. So I will go directly to the prevalence of the HER2 ultra low among patients with advanced breast cancer with historical IHC 0 status. So these are the pre-analytical factors. It includes the sample collections, fixations, storage, and the ends in reporting and the interpretation. So there are multiple sources of variations in the IHC interpretation. It starts with the pre-analytical, analytical, and the post-analytical factors. So standardization of the practice, quality assurance program, and automation have potentials to be of significant impact. So these are the standard SOP which I follow in our lab also. This is the sample collections, sample processing, and transport, storage, followed by the IHCs. And the importance of the ensuring the cold ischemia time is also important. It has to be 30 minutes to 2 hours. So cold ischemia times and fixation influences a lot. Fixation time in 10% of neutral buffered formalin should be between 6 and 72 hours. And sections should be 5 to 10 micrometer thick and cut within 6 weeks of the HER2 staining. So old slide should be discarded, and the cold ischemic time should be as short as possible, ideally within 1 hour, or you can say 30 minutes to 2 hours. And impact of the storage of the sections of the HER2 testing also influences a lot. The signal intensity decreases over time, and the sections which are stored more than 6 weeks should not be used for HER2 testing. So you can see here the freshly cut sections at less than 1 week and old sections of more than 6. You can easily see the difference between the quality of the staining. And similarly, the freshly cut sections of less than 1 week and old sections at more than 6 months, you can see the same case. You can see the difference. So why I am saying this? Because the interpretation directly correlates with the prognosis and the therapy. So you might report a HER2 3 plus case to HER2 1 plus or 0 plus. So the old cases should be disregarded. Old biopsy should be disregarded. More than 6 months old, you can go for a fresh biopsy and a fresh IHC testing, because the signal intensity varies and it is rapidly decreases if it is stored more than 6 weeks. So the key takeaway is that getting updated information from the ASCO cap is extremely important. You must know when to call it HER2 low and HER2 ultra low, and the definition of the low and ultra low should be correlated with the standard histopathology microphotographs which are there in various websites. In the AstraZeneca also they have, in the Ventana, in the Roche website also they have published quite a few good photographs of standard photographs. One can take help from that. And in order to provide benefit of targeted therapy, the updated guideline has to be strictly followed. The footnotes need to be mentioned, and the percentage of stained cells which you are taking as a positive has to be mentioned in the first bracket. And the role of the second pathologist, where there is a diversity in the staining pattern is there, has to be considered. And pre-analytical factors need to be kept in mind. And the template footnote reporting system or the synaptic reporting system must be implemented. So thank you very much.
Thank you. Thank you, sir. Thank you so much for your insightful and practical presentation. Now we move on to our last session of our day, focusing on refining treatment options for metastatic TNBC. This discussion will be moderated by Dr. Nitin Raj Daniel, joining him with our expert panelist, Dr. Vijay Sharnagat, Consultant Medical Oncology, HCC Cancer Center, Mumbai. Dr. Gautam Santosh Panda, Medical Oncologist, Bagchi Sri Shankara Cancer Center and Research Institute, Odisha. Dr. Sushil Kumar, Senior Consultant, Medical Oncology, American Oncology Institute, Raipur. Over to you, Dr. Nitin and panelists.
Very good evening to everybody. So am I audible?
Yes, sir.
Yeah. Okay. So I'll start off with the main topic, that is refining treatment options for metastatic TNBC. So initially we did not have many treatment options. Now suddenly there is a flurry of options, and many a times we are confused about what to do next. So in this case-based panel discussion, I have my esteemed panelist, Dr. Vijay Sharnagat sir, working as a consultant in HCG Mumbai, Dr. Gautam Santosh Panda sir, working as a consultant in Bakshi Sri Shankara Cancer Center, Odisha, and Dr. Sushil Kumar Yashala sir, who is a senior consultant at AOI Raipur. So we have got a puzzle to solve, and I'm hoping that I'll be able to deliver justice to the knowledge that our esteemed panelists have. So coming to the breast cancer, around 15% of the breast cancers are triple negative. Traditionally, metastatic breast cancers have got a very poor survival, with majority of the patients surviving to maybe around 12 to 15 months. So now the survivals have actually gone up. So previously, we just had our chemotherapy, we just had our paclitaxel, docetaxel, everything, and suddenly we have got this HER2 low targeting, we have got immunotherapy, we have got TROP2 targeting, and there is a huge heterogeneity, as we all know, and the weapons which we have in our hand right now are the PD-L1 positive, where pembro is a good option for us. There is actually germline BRCA mutation, talazoparib, olaparib. HER2 low, we have got TDXT. MSI high, again, we have got the pembro, dostarlimab. TMB high, again, pembro is there. NTRK, we can target. RET also we can target. But I think we'll primarily focus on the first three points, which are actually very game changers at this point of time. So coming to my first case, so a 52-year-old female who has presented with liver metastasis, upfront, the de novo liver metastasis, lung metastasis, and the biopsy from the liver metastasis confirms a ER/PR negativity and a HER2 zero positive. The patient is ideally a candidate for systemic therapy. So my question to my panelists would be PD-L1 status. So what are the key tests which are required to decide what treatment will you give? Vijay, sir?
Yeah, hi. So for this patient, so this is triple negative breast cancer. She has metastatic disease. and biopsy again is suggestive of triple negative disease only. So the marker which I probably go would be a PD-L1 test. Germline BRCA testing must have been done like before only, or if she is denote metastatic disease, then I am going to do BRCA status and NGS test. So broad panel, so which is going to include so most of the mutations. So 500 gene or 1000 gene panels probably I will consider, and depending upon the results, so maybe the treatment can be carried forward.
Gautam
Yeah.
sir, do you prefer getting a NGS test upfront, or like do you wait, sir, or like we just look at the PDL1 or the BRCA, or the panel, sir? Do you look at the entire panel? Like, can you just throw some light into that, sir?
Yeah. So maybe on the day one only, I will advise all the tests if they are not done on day one only, and maybe so depending upon the disease status, disease burden, I have to start some form of the treatment rather than waiting for the reports.
Okay,
Yeah.
so here we like exactly like how Vijay sir had advised. We have gotten a PDL1 test done, and CPS score was around 0%, and germline BRCA2 was positive. So my question to Gautam sir, are you available? Gautam sir?
Can you please repeat the question? Sorry, I just.
Yes, yeah, sir. So it is basically 52-year-old de novo metastatic
Yes,
TNBC with a
yes,
triple negative, PDL1
yes,
0%, and a germline BRCA2 positive, sir.
yes,
What
yes.
would be your ideal approach in this patient, sir? How would you manage? What
One,
systemic therapy? Would you want to go with a singlet or
yeah,
a
please.
doublet patient?
So,
Sir, you're not audible, sir. Gautam, sir? I think Dr. Vijay sir, can you take this question?
Yeah. So CPS is more than 10%.
No,
And
CPS
no,
is
so
0%,
CPS
sir.
is 0 and BRCA is
BRCA is
positive.
positive.
Yes. So definitely, so I would go with the PARP inhibitors, probably olaparib, and see, rather than going for the chemotherapies and other treatment options, first I'm going to consider PARP inhibitor because the toxicity when I'm going to consider means with this PARP inhibitor are like different, and chemotherapy toxicity is a little bit different. So an efficacy of the PARP inhibitor is better in the earlier lines than the later lines. So my
Okay.
preference would be the PARP inhibitors.
Sushil sir, like, do you also agree with the same, or do you have a
Kind
different
of,
take on the same,
but
sir?
here I would like to add some point that the patient is having liver and lung mets. So firstly, I would like to rule out whether the patient is in any visceral crisis or not. Because if the patient is in visceral crisis and if we start on PARP inhibitors, it will take time and it may not work or the PARP inhibitors are not very responsive in the beginning. So first I would like to rule out the visceral crisis. If visceral crisis is there, despite being GBRCA positive, first I would like to deliver chemotherapy, control the disease, and can start on the PARP maintenance. But however, if the patient is not in visceral crisis, directly I would like to start on PARP inhibitors.
So, sir, your symptom burden is definitely one of the criteria which will make you choose what treatment would you go, sir. So, if you're going for a chemotherapy, what chemotherapy would you go for? A singlet chemotherapy or a combination chemotherapy?
Both are options as per the ESMO. But however, PARP inhibitors, we know they are sensitive to platinum agents. So my preference would be I would start with the platinum agent.
The platinum itself, sir. So, is there any other like age cutoff or anything of that sort where you actually decide regarding whether you will go for a chemotherapy, singlet, anything of the other sorts, anything else which will make you choose one over the other?
Prior exposure, if the patient is the the comorbidities, if the patient had prior is a known case of type 2 diabetes, if the patient is having neuropathy, I would like to avoid taxanes, or if the patient is having pre-existing heart issues, then I would like to avoid anthracycline-based therapy. So the multiple factors we take into consideration while deciding upon the therapy.
And sir, do you what is the optimum duration which will you till when you will give the chemotherapy? Will you stop at 6 or will you go beyond 6?
Chemotherapy, we know we cannot extend, we cannot drag beyond a particular time. So in this case, I think we can consider for if at all the patient is not in visceral crisis, then I would start with the PARP inhibitors. But if the patient is in visceral crisis, then I would like to control the disease with maybe 6 to 8 cycles, and then stop the chemotherapy and then continue her upon PARP inhibitors.
Okay, so like how Vijay sir said, Olympiad trial has given us a strong data for using a PARP inhibitor upfront, where the overall survival is definitely comparable with the physician's choice chemotherapy, where we had the platinums and the taxanes and everything. Gautam sir, are you there?
Yes. Just technical glitch.
Sir,
Sorry.
is there your take on the same, sir? Metastatic TNBC, PD-L1 negative, PD-L1 0%, BRCA positive, chemo versus PARP inhibitor, sir. Which one would you choose?
So, if the patient is too much symptomatic, I would start on the chemotherapy. If the patient is mildly symptomatic and it is controlled, then I would start on the PARP inhibitor, basically.
Okay, sir. And chemotherapy, sir, again, like 6 cycles and then maintenance PARP?
Yes.
Yes, sir.
Yes.
Vijay sir, like, what is your take on this ASCENT trial, sir? Because now chemotherapy versus sacituzumab, this is more of a theoretical discussion since sacituzumab has not come to India. Sir, we have seen the results of the ASCENT 3 trial where sacituzumab was compared with chemotherapy in PD-L1 ineligible patient, either because patient due to comorbidities or CPS is low, they have combined SG with chemotherapy. So there was a PFS benefit in the first line, and all the subgroup analysis, majority of the patients actually showed that there is a better response, and the duration of response also was very good, sir. So, but again, coming to the side effect profile, we have got a different side effect profile, sir. Given all these data, sir, would you consider chemotherapy, PARP inhibitor, or a SG, sir, in this scenario?
Yeah, so in this situation, so I would preferably go with the PARP inhibitor first, maybe in the later lines. So if PARP inhibitor is not functioning, it's not working, and we got progression on the PARP inhibitor, then in this situation, SG is considerable. So because looking at the data, response rate, PFS benefit, OL benefit, definitely I would be more inclined towards this SG than the chemotherapy molecules. Maybe in the later lines, means immediately after PARP inhibitor, I may consider this option.
Okay.
Yeah.
Yeah, Gautam sir, you agree, sir? With the advent of the newer, again, we have got the data of datopotamab, Tropion trial has come out. We have got sacituzumab govitecan and everything in the, yes, sir.
No, you are right. You are right.
Yes, sir. So, would you still stick on to how would you like to sequence, sir? Because right now the PARP inhibitor plus sacituzumab or the ADCs are coming up more. The data is actually now getting more day by day. So, in this scenario, would you consider a sacituzumab govitecan or a datopotamab before PARP, after PARP, before chemotherapy, sir? Can your take on that, sir?
So, PARP inhibitor should be used as soon as possible, because the action basically the benefit of the PARP inhibitor diminishes as we use it down the line of therapy. So it should be used in the front line here basically. And regarding chemotherapy, I don't think the OS will be similar whether we use it in the first line or the second line. And regarding SG and datopotamab, it has to be seen. These are two basically new molecules which are being used and very new for me also. So I can't comment on these two basically.
So, Sushil sir, your take on this, sir? Because Tropion trial, again, they have combined dato with chemotherapy, and there was again a PFS. I think it is the first trial of ADCs in the first line metastatic triple negative, which has actually shown a OS benefit. So, given these two trials, sir, what is your take on the entire scenario in the first line, sir? PDL1 negative.
Yes, yes. But we need to understand one thing, that Olympiad trial is a first line trial if the patient is BRCA positive, and so we start with the PARP inhibitors. The Ascent trial, if you look at the inclusion criteria, it is 2 or more lines of therapy, prior 2 or more lines of therapy. So when we speak of sacituzumab govitecan, it is in the second line or beyond second line. It's not in the first line. So just because we got a new molecule, we cannot shift it to the first line. That is my point. Next thing is, again, if you look at the datopotamab, it is in the first line. So if you look at the inclusion criteria of the dato trial, it is no prior therapy. So all the inclusion criteria of all these trials are different, and we need to look at how we can include the patients in the respective line. So Olympia trial is a first line, dato is a first line, Ascent is a second line. So if at all the patient on PARP inhibitors later progress, then we have option of SG. That's how I look at it. Am I audible?
Yes, sir. Okay. So here the patient was started on paclitaxel plus carboplatin. Yes, sir. So in this, so ideally, like we can either start chemotherapy or olaparib, and then we can sequence accordingly. If at all it comes, then we will definitely look at further OS data, and again we'll have to look at the first line data. So now our first line in a PDL1 negative population is kind of clear in a BRCA negative and a BRCA positive patient. So the patient here was started on chemotherapy with paclitaxel plus carboplatin. She had gotten a PFS of around 7 months, and she got progressive disease in the liver. So the repeat biopsy from the liver lesion showed ER/PR negativity, and HER2 was 1+. So again, the question to Vijay sir. Sir, ideally, yeah, I think we have all agreed that all the panelists would agree that we need to do a repeat biopsy in all the patients. Any difference of opinions?
Yeah, definitely should be considered. Repeat biopsy should be considered. And now this time it is HER2 +1. And we did not use PARP inhibitor in the first line, and we had used paclitaxel and carboplatin. And on paclitaxel carboplatin, the PFS is 7th month. So now this is the time where we can either consider PARP inhibitor. I think we should consider PARP inhibitor, and maybe later on there is option about this TDXD because it's +1, so that can be considered.
Sir, clinically, like, have you gotten good responses with PARP inhibitors, sir? Because I never had the confidence to give it in the first line. I always am very scared.
Okay. Yeah, really. But see, for this patient, we started with the paclitaxel and carboplatin.
Yes, sir.
So we did not start with the PARP inhibitor. But see, this data, so see, I know that there's scary data about TDXD also. If we are going to see the ILD component, so that is also very scary. But still, we are starting TDXD.
Yes, sir.
Yeah, but this is also means we can plan. See, because PARP inhibitor, they are going to show good efficacy in the earlier lines of the therapies, not in the later lines of the therapies. So that's why it's better to start PARP inhibitor whenever BRCA positive patients are there. So we should consider PARP inhibitor in the earlier lines.
Yes,
so to get better efficacy and lesser toxicity. The toxicity which I had seen with the PARP inhibitors are like anemia, severe anemia, fatigue, and vomiting. So, means safely can be managed.
Okay, sir.
Yeah.
Sir, one more question, sir. When do you consider liquid biopsy?
Liquid biopsy, see, if patient is not ready to do biopsy, and so biopsy means getting biopsy from site, it is very difficult. Maybe it is not possible for radiologist to take a biopsy sample. Or else, so when I'm sending some comprehensive genomic panel, so where biopsy and liquid biopsy, I'm planning to send it together to get a better results. So that is the situation. Yeah.
Sushil, sir, do you agree with the same repeat biopsy, liquid and repeat biopsy? Do you send for everybody, sir?
In the beginning, we would like to do PDL1 and also GBRCA. So GBRCA is a blood test, germline, and PDL1 and IHC testing are basically, HER2 are basically IHC testing. So liquid biopsy, when we talk of liquid biopsy, we are basically looking at any other clinically actionable biomarkers. We are basically looking that would be our main intention when we consider for the liquid biopsy. So when all the options are exhausted, when in the both 2 lines, 3 lines, we have given TDXD and still the patient is fit enough to receive some kind of therapy, that is the situation when I would like to consider for liquid biopsy so that I can, with the aim to find out any targetable mutations.
Okay, sir. Sir, do you actually go for the CGP panel or do you go for very targeted panel, sir?
So in all cancers, like if at all, when the patient is in the 3rd line, 4th line setting, then definitely we would like to consider a CGP. Or else upfront focus panel would be economically feasible for most of the patients.
Okay. Gautam, sir, can you shed some light on the same, sir? Sir, your take on the same.
So repeat biopsy for all, definitely if possible. And in addition to ER/PR HER2/neu, I would also like to test AR because quite a few of the TNB's patients have AR positive. So AR can be targeted and it is cheap also, though there is no strong evidence for it. Second, for liquid biopsy, if the patient is affording, then it should be done because it may give rise to some other tumor agnostic markers which might have been missed in the tissue biopsy or the NGS. And questions meaning low.
Sir, no. Like, do you routinely practice sending liquid biopsy for everybody or just the tissue biopsy and then we'll stop at that, sir? And
Yeah, liquid biopsy
second
I
thing
don't
is,
practice routinely. I just do the repeat tissue biopsy and send ER/PR HER2/neu and AR basically. And PDL1 if it was not done earlier.
okay. Sir, and do you send as CGP or you prefer to do a very targeted panel, sir?
If the patient is affording CGP, if not affording, then the tumor agnostic markers at least, like
Sir,
HER2/neu, RET, all these.
sir,
That
many
to be included.
what happens is we send it and we get some very atypical mutation and we are just
Yeah,
confused.
uh.
Back in the soup, so it throws us there will be this mutation, that mutation, which you have never heard of. So how do you navigate that, sir?
So it has to be discussed with the molecular pathologist actually. So the report is very confusing. First, we have to check the read, the WEF, and the mutation likely pathogenic. All those has to be discussed with the molecular pathologist actually. If you are doing a CGP, so I generally avoid doing a CGP. I generally do the tumor agnostic marker at least, and if one of them is positive, I can consider for it after all the treatment lines basically.
So Vijay sir, back to you. Like sir, how will you? Okay, we have used the PARP inhibitor. So in this, if we had used the first line PARP inhibitor, second line, sir, what would you have chosen? Would you have gone with the chemotherapy, or would you target the low HER2 since it's 1+?
Yeah, probably I will target HER2, means HER2 1+, HER2 low, probably with the TDXT.
TDXT.
Yeah.
Okay, Sushil sir,
I
your
completely agree
take on
with
this.
Vijay sir. I would like to target the HER2.
Okay. Gautam sir, agree? DB04 data is very convincing, sir.
Yes, yes.
Yes, so Ascent again, sacituzumab is again an option here, but again, how Dr. Sushil sir told, with two chemotherapies, definitely it will definitely help. So I think then further lines down the lane, do we have any other different chemotherapy options? Like we'll have the liquid biopsy or a CGP guided, a DMMR targeting the tumor agnostic therapies. Or other than this, does a panelist have anything to add on to this in the further lines? Okay, we have chosen a PARP inhibitor. We have had a TDXT. Then we come to our traditional sequencing of chemotherapy plus or minus tumor agnostic therapy in between, sir. Do we agree on this, sir? Any different take on this, sir? The panelist general opinion before we wind up the first case?
No.
Yes, sir?
No. Yeah.
No, agree, sir?
Yeah. I agree.
Okay.
Agree. Yeah.
Yes, sir. Thank you. Sir, moving on to the second case, the patient is a 42-year-old female. So she was diagnosed in 2022 with a right-sided breast cancer, IDC grade 2, clinical T4, N2B, M0 disease, ER negative, PR negative, HER2 1+ then with Ki67 of 40 to 50%. She was then undertaken for the chemotherapy dose-dense regimen, and then she proceeded with the MRM, and there was a pathological complete response. So the patient was kept on follow-up. So she had a PFS of around 2 years. Now the patient presents to us with a headache. So MRI actually showed a right parietal lobe lesion of 5 into 3 centimeter with perilesional edema. So automatically we went ahead with the PET CT. There were no lesions elsewhere, sir. So first question to Sushil sir. Sir, how does routinely your TNBCs relapse, sir?
So it can relapse in the organs, either visual organs, mainly in the lung, liver, and brain. So these are the three frequent relapses I see in my clinic.
Gautam sir, how do you, just out of curiosity, how do you follow up, sir? Do you go for a PET scan during the follow-up period, sir? Or do you just conventionally just look at the mammogram and clinical evaluation, sir? Just the thought on this, sir.
So clinical evaluation only, no routine imaging is done. So clinical evaluation, if the patient is symptomatic or we find something on the clinical examination, then we do a scan basically.
Vijay sir, more and more patients are these days coming and asking for PET scan after 1 year, PET scan after 2 years. They'll have some international, a new job to take up. Sir, do you do just clinical examination, or do you actually go for any scans in between, sir? Because
No, I'm looking at, means according to guidelines. So routinely I don't do follow-up PET CT scan for breast cancer patients. So mammogram, and whenever they get any kind of the complaints, so the scan pertain to that part. So that is first thing. But see, triple negative breast cancer, so they are very heterogeneous. So currently I have two patients. So one patient, she had completed therapy, got pathological CR, and after 3 months, she presented with severe headache and she got a leptomeningeal disease. Unfortunately, she was BRCA positive, started with the PARP inhibitor, and she's doing very well now. Another patient, so she was on a neoadjuvant chemotherapy. So completing 4 cycles of paclitaxel, 2 cycles of AC, she started getting headache. And similarly, she also got leptomeningeal disease. And there is CR in the breast. So with the 6 cycles, there is CR. So this is like a different situation. So monitoring patients. So how means see later on. So we cannot do these kind of investigations. So we have to do investigation depending upon the symptoms, because we cannot predict symptoms. One of my patients, she had only mild chest pain. So for 1 or 2 months, and when CT scan was done, so she got multiple lesions inside the lung, and so she was also triple negative breast cancer. So when we are doing a routine checkup, clinically we are assessing patients, the symptoms, and then when we are performing investigations, then we are getting something. But profile means routine, I'm not doing any scan.
Yes, sir. Totally agree with your point, sir.
Yeah.
Sir, just like if it's a metastatic triple negative breast cancer, upfront presenting, for example, like with the other patient, the lung and the liver mets, sir. So do you recommend a screening MRI for brain? Because now there is a thought process that if you find out a brain mets early, we can go for a surgery, we can give an SRS, we can go for, we can actually avoid the whole brain RT, sir. So can you your take on that, sir? Because lots of PGs are there. So your take on the same, sir.
See, so if PET scan is not able to see the lesions inside the brain, so maybe MRI, we can get multiple lesions. So a smaller lesion, single lesion less than 1 centimeter, where we can consider for surgery. So larger single lesion, we can operate, remove by surgery, or at least we can consider for SBRT. So the tumor less than 2 or 3, less than 2 to 3 centimeter can be considered for the SBRT also. So this is like surgery and SBRT means radiation therapy. The rest of all brain lesions we have to consider for the whole brain radiation therapy. So that is not a curable option. A single lesion, surgery or SBRT. So lesion larger than 3 centimeter, I think it's very difficult to go with the SBRT. So then we should consider for the surgery. So smaller lesion less than 3 centimeter, definitely and a single lesion. SBRT should be considered. A lesion which is alone, where you have doubt about the hormonal status and you want to evaluate the hormonal status of the breast cancer. So then maybe you have to discuss with the patients to get a histopathological examination and its reports, because it is going to help you about the management. So can be considered for the surgery and maybe RPRI reports on that.
Okay. So moving on to the next part. So this is again a 47-year-old female who has relapsed with a solitary brain mets. Sushil, sir, your take on how to proceed in this case, sir?
So if surgery is feasible, then definitely I would like to discuss with a neurosurgeon and proceed with the surgery, because that will also help in addressing the disease. And also we can do histopathology testing and IHC testing on because there is no other site of disease anywhere in the body other than brain. So, and we know that relapses, the IHC status can change. So my preference would be to do surgery feasible and do a IHC, ERP or HER2 status on the brain tissue.
Sir, if there was a mets somewhere, sir, for example, a solitary liver mets or a lung mets, sir, would your approach change?
Again, then the approach is two options. One option is always I can take the histopathology like the core biopsy from the liver or lung lesion for whatever the IHC I require. Regarding the treatment, yes, if the patient is willing, definitely we can go proceed with the surgery. But if the patient is not willing, then the SBRT solitary lesion, if it is smaller size, then SBRT is a other option.
Gautam, sir, your take on the same, sir, surgery, solitary lung mets versus somebody who has gotten so much of systemic mets, sir, but solitary brain mets. Would you, in these two cases, would you go for an upfront surgery or would you go for a SBRT, sir, in both the cases, sir?
So if it is a brain only lesion basically, and extracranially there is nothing. Then surgery followed by SRS if possible. And if there is a single met outside the brain, if there is a single met outside the CNS and the primary is controlled and the patient is in a good GC, I would like to consider brain radiation and radiation to the basically mets wherever it is the lung or liver, followed by systemic therapy like chemotherapy or whatever is there.
Sir, Vijay sir, your take on the same, sir. And then what to do next? Would you actually give a systemic therapy since there is no extracranial relapse? Would you start a systemic therapy, and whether you agree with the other panelists, sir, for the same?
And I would like to add that here comes the main role of the ctDNA. If we would have done the biopsy and the liquid biopsy earlier, we would do a liquid biopsy here also to check whether there is any ctDNA which is positive or rising or not, because systemically outside the brain there is some rising ctDNA. It would be a bad prognostic thing basically.
Okay. Sir, so she underwent actually an excision, and it was again proven to be a ER negative, PR negative tumor, and NGS 161 gene, the extensive panel was undertaken, and TP53 mutated NTRK amplified VUS was there, and PDL1 was actually, CPS score was 22%. So in this case, Gautam sir, your take on how would you sequence her? We have got a brain relapse patient with a PDL1 score of 22 CPS, sir. What would be your first line? How would you sequence your therapy, sir?
So it is NTRK positive, na? If I'm not wrong.
Yes, sir. NTRK amplified.
NTRK amplified. Then
PDL1 is positive.
How much is this? 22, na?
CPS 22.
CPS 22. Then I would like to add entrectinib to the patient basically, because it acts on the brain also and it acts systemically also.
Sushil sir, your take on the same, sir?
I would like to go with the immunotherapy with chemotherapy because the CPS score is 22% and NTRK fusion. I think entrectinib works with the NTRK fusion, not amplification, if I remember correctly. But please correct me if I'm wrong. NTRK amplified will not. I think NTRK fusion is the one where entrectinib acts, not the amplification. And though even if it is a fusion, even we have, but I think CPS is 22%, and we have the phase 3 randomized control trial data. So I would definitely go with the immunotherapy with the chemotherapy as per Keynote 355.
So, like, the patient has not systemically failed, but still you would want to go with the systemic therapy, right, sir?
Yes.
Yeah. So we'll stick on to the Keynote protocol. Yes, sir?
Yes, I would
Yes,
go
sir.
with the Keynote.
Yes, sir. So I'll just throw some light on some the newer trial, which is actually Ascent, sir. So in Ascent 04 trial, the chemotherapy with pembrolizumab, which was been the standard of care for 3 years now. So sacituzumab govitecan with pembrolizumab has been compared in this trial. So here actually we have not gotten the OS data or anything, and not gotten the full paper also. So there is actually a clear benefit. So the SG plus Pembro has actually shown a median PFS of 11.2 months with versus chemotherapy plus Pembro. And the toxicity is definitely, that is a neutropenia, fatigue, everything is more. So would you consider changing your practice, a chemotherapy plus Pembro or if at all SG comes over, would you want to change to SG plus Pembro, sir?
So, if the patient is young and fit, affordable, then we may consider, but at the cost of toxicities. So toxicities are higher with this combination. But still, that's an option. Like both, I would consider that it's also an option rather than practice changing. I would just consider that yes, we have SG with IO versus chemotherapy with IO.
Gautam sir, she has progressed after 7 months, good DFS with chemotherapy plus Pembro. First question is, would you agree with the first line, the chemo plus Pembro? And second line, what would you prefer, sir? Would you go for a TDXT sacituzumab or chemotherapy or immunotherapy rate challenge? I don't think that is very valid. What is your take on the same, sir? So first line chemotherapy plus immunotherapy, second line ideal option, sir, in this case. Gautam sir, you are there, sir? Sushil sir, can you take this? I think we are out. Yeah.
If it is HER2 low, then definitely second line I would consider TDXT, considering a strong data. But if the patient is HER2 0, then yes, SG is an option. Sacituzumab is an option.
So if it is PD-L1 positive, our main thing would be chemotherapy plus pembrolizumab, and second line would be TDXT if HER2 low. Otherwise, sacituzumab govitecan. And third line only the chemotherapy comes. So that is the take-home message today. Our first line and second line has actually undergone a lot of change, but still the overall survival has touched around 24 months, if I'm right, with the keynote trial. So we have gotten a long way to go, because we have reached somewhere else we have reached like 5 years and everything with the other hormone positive or HER2 positive tumors. So right now, the main focus of treatment would be immunotherapy and targeting the TROP2 or a antibody drug conjugate ADCs. So that is the way forward. More and more trials are being done with the ADCs with the immunotherapy ADC with PARP inhibitor, immunotherapy with PARP inhibitors. Again, bispecific antibodies are being taken. So at present, this would be a proposed algorithm. And I think that is the end of our presentation. And I would love to thank my esteemed panelists for tolerating me for this much of time. And
I would like to add a point here.
Able to deliver justice to my topic.
May I add one point over here?
Yes, sir.
May I add one
yes, sir.
point?
Yes, sir. Please go ahead, sir.
So
yes, sir. Please,
major
sir.
Major unmet needs, I think we have option of immunotherapy and PARP inhibitors for the patients who are PD-L1 positive patients and BRCA positive patients, germline BRCA positive patients. But what about the PD-L1 negative patients? So that one we need to look into that. And when we consider for the PARP inhibitors, it's mainly the trial inclusion criteria is based on germline BRCA mutation. So not T-BRCA or not HRD as we do it in ovarian cancer. So what if the patient is T-BRCA positive? What if the patient is HRD positive? Still the patients are not eligible for the PARP inhibitor. So we need to look into these all populations who are not eligible for the routine IO or PARP inhibitors. We may need to focus on these things, and further trials should come up focusing on these unmet needs.
Thanks, sir. Thank you for that insight, sir. So I would like to hand this over for the vote of thanks. Roshni?
Yes, sir.
There? Yeah. So yeah.
We'll have a quick vote of thanks then. So first of all, I thank all the panelists for those valuable insights and interactive session. As we conclude today's expert insights on breast cancer, I would like to extend heartfelt gratitude to our program director for making more efforts at the last moments, and gratitude to our distinguished speakers and panelists for their time and expertise, and to all the participants for being part of this engaging academic session. Thank you, Nitin sir, for curating this impactful scientific program. And I hope everyone will be joining IIO team for the continued efforts in promoting oncology education and collaboration. Thank you, sir.
Thank you for this opportunity.
Thank you.